Good evening and welcome to our SARA webinar. SARA is the Scottish Allergy and Respiratory Academy, and we run a series of webinars on a range of important topics in respiratory and allergy. Tonight our topic is on chronic obstructive pulmonary disease, and we've got three really important talks for you, key issues as we manage our patients with COPD. I'll introduce the speakers in a moment, but first of all, I need to just give you a few housekeeping rules. We're delighted to have you attending this webinar, but unfortunately we can't allow you to share your audio or video. However, we do want you to interact with us, and you can do this via the Q&A panel. If you look at the bottom of your screen, you will see a Q&A slot. And if you want to type your messages in there, your questions for the speakers, do that as we're going along, because we've got a 5-minute slot after each of the speakers, and we'll be able to cover some of the questions there. So keep them coming in, and we will ask the speakers for you. We have got a slot at the end as well where we can ask a few more questions. So keep them coming as you think of them. If you like somebody else's question and you want to use the thumbs up icon, that tells us which are the priority questions, and we'll prioritize those if time is short. I need to tell you that this webinar is being recorded, and it will be posted on YouTube, and people will be able to access it on YouTube or via the SARA website. I also want to thank our sponsors, Viatris and GSK. We're very grateful to them for sponsoring this event, which enables us to bring it to you without cost. We're very grateful to them, and I need to explain that these are educational grants. They have had no input of any sort into the programming or the speakers or the content. They are unrestricted educational grants, but thank you very much to Viatris and GSK for making this webinar possible. So I will now introduce our three speakers. All of whom are going to be talking on different aspects of COPD. The issue of antibiotics for treating acute exacerbations, that all-important topic of multimorbidity, and the absolutely fundamental issue of helping our patients with COPD quit smoking, the only intervention that's actually going to alter the long-term outcome for our patients. So three really important topics. So moving on to our first speaker, I'm delighted to welcome my friend and colleague Nick Francis, who is a GP in Southampton and Professor of Primary Care Research at the University of Southampton. He's very interested in antibiotic use and infections, and the study that I think he's going to tell you about today is, I think, one of the most important studies I've read for a while, and certainly one that we should all be thinking about when we see our patients with COPD. We know how frequently some of them come to us saying their chest is worse, they want antibiotics, they want steroids. It's quite a challenge sometimes to know when these treatments are appropriate. And the study that I know Nick is going to tell you about answers at least some of the questions for us. So thanks very much, Nick.
Thank you very much, Hilary. Good evening, everyone. I'll just share my screen there. Hopefully that, hang on, share. Okay, hopefully that is working. Yes, thank you very much. So I'm a GP in Dorset and a Professor of Primary Care Research at the University of Southampton. And I've been asked to talk to you about use of antibiotics for acute exacerbations of COPD. Here's an outline of the talk I'm going to give. And I'd like you just to take a moment and just reflect on these questions. What you could even jot them down on a bit of paper if you feel so inclined. What do you think are the main causes of acute exacerbations? in particular, what proportion are caused by a bacterial infection. What proportion do you feel of consultations in UK for acute exacerbation of COPD are treated with antibiotics? What are the harmful effects of antibiotics, and how can I better target use of antibiotics to those who are most likely to benefit? So moving straight on to the first one, the main cause of acute exacerbations in the primary care setting is probably viral infection. Depending on the study and setting, you can detect viral pathogens in up to 70% of acute exacerbations. Now, a word of caution here, these are usually molecular studies looking at detecting nucleic acid, and you can detect very small amounts of nucleic acid. So you can detect viral nucleic acid in patients who are not having an acute exacerbation as well. So we may be overestimating, but the main viruses, rhinoviruses, enteroviruses, human metapneumovirus, coronaviruses, and I'll mention a bit about SARS-CoV-2 more at the end, influenza, parainfluenza, so the usual kind of suspects. Around 40 to 50% of exacerbations are associated with a bacterial pathogen, but again, the same caveat, this is being able to detect a bacterial pathogen, this time usually by culture, but we know that people with COPD often carry bacterial pathogens without causing clinical manifestations. So you can detect bacterial pathogens in people between exacerbations when they're feeling well. So again, a slight overestimate by just looking at being able to culture the bacteria. But the main pathogens, Haemophilus influenzae, Moraxella catarrhalis, strep pneumonia, Pseudomonas. So now, this is data from our PACE study, the study that Hilary was talking about, and I'm going to mention again. But so this was a community-based primary care study, and we found that we were able to detect bacterial pathogens in about 40%. But if you look at the bar chart on the right here, actually quite a lot of those were co-infections. So there was bacteria and virus. So we got about a quarter where we detected no pathogens, about 1 in 5 where we detected a bacteria with no virus, around a third where there was just a virus, and about a quarter where there was both a virus and a bacteria. And that's quite commonly shown in literature, where you get a sort of co-infection, usually a virus initially, and then that triggers off a bacterial secondary infection. Okay, moving on to the next question. What proportion of primary care consultations for acute exacerbations end up in a prescription of antibiotics? Well, it's between 70 and 80%. In this data from CPRD, we found about 80% of consultations back in the sort of 2007 to 2012, but that's been declining. So it's closer to 70%, 75 to 70% now. Significantly higher than the sort of 20 to 40% that have a bacterial exacerbation. And there's also wide variation between practices. So each one of these tiny little bars represents a practice contributing CPRD data in the UK. And you can see that it varies from around 20% of consultations up to 100%. And how effective are antibiotics for acute exacerbations? Well, this forest plot is from the Cochrane Review, and in the outpatient setting, the answer is a little bit, but that is probably because you've got a number of patients who benefit substantially from antibiotic treatment, but the effect is really diluted by the large numbers who are not benefiting at all. Okay, harmful effects of antibiotics. Well, I'm sure you know all this. The antibiotics cause side effects. I think we sometimes minimize this, but you know, a large number of patients will get adverse effects like diarrhea, vomiting, rashes. yeast infections. And so, it's important not to sort of over minimize those. Antibiotic resistance, again, we all know about that, a major public health problem, and our use of antibiotics does contribute to that. But it's not just about the public health issue. The patient that you give antibiotics to, as we mentioned before, a lot of them will be colonized by pathogens. And when you give them antibiotics, that helps to select for the resistant pathogens. So when that patient has had a course of antibiotics, they're much more likely to have a resistant infection in the future. So you're actually potentially harming that patient by giving them antibiotics. And then finally, there's the microbiome, and particularly the gut microbiome. And it's an evolving story, but there's increasing evidence that when we give patients antibiotics, it has harmful effects on the microbiome. And this has been associated with things like obesity, diabetes, autoimmune diseases, autoinflammatory diseases. So it's an emerging area, but we potentially do a lot more harm to patients than we think. Okay, how do you target antibiotics? Well, this is what NICE says. It's fairly vague. They say you should consider the severity of symptoms, particularly sputum color changes, an increase in volume. They should think about risk of complications, but actually when you look at the NICE guidance on complications, they talk more about sort of complications of the long-term condition, like depression. If you've got culture results, you should obviously take those into consideration. And if you are prescribing antibiotics, then you need to sort of think about the risk of antimicrobial resistance. GOLD guidelines are also fairly vague, and they also talk about when the signs of clinical signs of bacterial infection, such as increased sputum purulence. So sputum purulence and volume, these are both part of the Antonison criteria. The Antonison criteria are the main criteria that have been used for many years, and they were based on a study that Antonison conducted back in the 80s, where they looked at the number of patients with these three features. And these three features, they were just based on their assessment of what was likely to be important. And they found that patients that had all three of these features were more likely to benefit from antibiotics. If you had two, you were slightly less likely. And if you only had one of these features, then you were much less likely.
Sorry, I couldn't hear what you said.
Sorry, it's my watch going off. And that resulted in area under the curve for predicting bacterial benefit from antibiotics of 0.7. Okay, moving on to our study. So this is the PACE study. We conducted a study to look at whether CRP point of care testing can be useful in helping to guide antibiotic prescribing in a primary care setting. And part of the background for this was a placebo-controlled trial comparing antibiotics with placebo for patients with acute exacerbations of COPD in the community. And they measured CRP, so it was randomized to antibiotics versus placebo, but they measured CRP in everyone. And they found that CRP was predictive of benefit from antibiotics with an area under the receiver operating curve of 0.732, so not bad. So we took that evidence and we developed a trial to see whether using CRP measurement could be help you to reduce or safely reduce antibiotic prescribing. We gave practices these desktop CRP machines. There's smaller ones available now, but these are the ones we used. And this can give a CRP result in under 5 minutes from a finger prick sample. And this is the guidance we gave clinicians. So we said if the CRP is less than 20, then antibiotics were unlikely to be beneficial. If it was greater than 40, then antibiotics were likely to be beneficial, and you should consider prescribing. And if it was in the 20 to 40 range, then they may be beneficial, and you should use other clinical features like sputum purulence to help decide. Now, this graph shows the distribution of CRP results from our study from those patients who were randomized to having a CRP test. And importantly, you can see that the vast majority, 76%, had a CRP value of less than 20, with a further 12% in that 20 to 40 range, and then only 12% greater than 40. So it shows you that the large potential here for reducing antibiotic prescribing. The vast majority of our patients have a low CRP value, got a low inflammatory response. So here's the outcome. So we randomized 653 patients, and we found that those patients who were randomized to having a CRP test were significantly less likely to receive antibiotics. So in the usual care arm, 77% received antibiotics. And in the CRP arm, that was a 20% absolute reduction down to 57%. And after adjusting for confounders or covariates, that was still a significant difference, about a 2/3 reduction in antibiotic use. But importantly, we didn't want to just reduce antibiotic use at the risk of harming patients. So we also measured, we had a co-primary outcome of COPD health status. And this was measured using the CCQ, the Clinical COPD Questionnaire, which looks at symptoms and functional impairment. And the highest score is a better health status. So we actually found that in the CRP group, this was measured at 2 weeks after they presented, so a week after finishing their antibiotics, and we found a higher, which is a better health status in the CRP group. This was statistically significant, but it's a small difference. It's probably not a clinically important difference. So we can't say that measuring CRP improves their health outcome, but there's certainly no suggestion that this led to any sort of adverse effect in terms of recovery from their exacerbations. Couple of other things. So we've done a secondary analysis using, again, the same data from the PACE study, looking at whether which factors were associated with finding these bacterial pathogens in the sputum samples. And interestingly, the main predictor of finding a bacterial pathogen in this study was sputum color. We used the bronchotest sputum color chart. You can see a small picture of one here. And I would encourage you to try and use an objective measure of sputum color. There is evidence that patients are not very good at assessing their own sputum color. So when you use an objective measure of sputum color, it doesn't necessarily have to be this one. You can see here from this chart, this table, those with the darkest sputum color had a 17 times the odds of having a bacterial pathogen in their sputum. Interestingly, in our data, CRP was not particularly predictive. It was predictive of finding bacterial pathogens, but also finding mixed bacterial and viral pathogens. Again, hard to interpret it's difficult to interpret that without knowing the sort of what's actually causing the inflammation, because sometimes you can identify them without the pathogens being causative. But this, sputum purulence, as we found, and as is identified in NICE and GOLD guidelines, there's a substantial body of evidence now suggesting that sputum purulence is associated with bacteria, finding bacteria in exacerbations. So certainly, I would say that sputum purulence is also an important feature in addition to CRP measurement. And just to finish off, just a couple of questions around COPD and use of antibiotics for COVID-19. Are patients with COPD at increased risk of COVID-19? Well, certainly when patients with COPD who become infected with COVID-19 are at increased risk of complications and severe disease. But they don't seem to be, people with COPD don't seem to be particularly at higher risk of developing, of contracting COVID-19 illness. And should they be treated with antibiotics? Well, antibiotics are not effective for COVID-19. In fact, there's increasing evidence that antibiotics like doxycycline are not effective in patients with COVID-19. So the guidance suggests that you shouldn't give people with COPD who have COVID-19 antibiotics unless there's a strong clinical suspicion of additional bacterial infection. So again, that would be your sputum purulence and your CRP, raised in CRP. Okay, that's it from me. Thank you.
Thanks very much, Nick. Such an important study. And I mean, the questions now, of course, are going to how we can implement and change our practice in the light of this evidence. I'd be interested to know, we've got nearly 60 people on this call. If anybody has access to point of care CRP testing, do you want to add something into the chat? Because I suspect it's not very many people, but it'd be interesting to know if there is anybody on this call. Apart from me, I have access to it in my practice, but it'd be interesting to know if anybody else could actually do this in their own practices. Now, we've got a few questions that have come in. So some of them, and just picking up on the COVID point, I think you've got a fairly quick answer to this. Have antibiotic prescriptions gone up during the pandemic?
No, they've actually gone down. The volume of antibiotic prescribing has gone down, probably largely because we're seeing less respiratory infections because patients have been socially isolating and picking up less viruses and contracting less respiratory infections. So I'm not sure about of the proportion that do consult, whether we're actually prescribing more readily. I suspect that might be the case, but if you look at studies looking at the volume of antibiotic prescribing, it's gone down.
Oh. The same is true of asthma, of course. Asthma attacks have gone down in the so COVID is good for you in some ways. Sort of. Janet Robinson has said, surely CRP will rise just because of COVID alone?
Yeah, I'm not an expert in this, but I think there is a degree. I mean, CRP has been used to help to predict outcomes from COVID. So not everyone with COVID has a CRP elevation. And those that do have a high CRP elevation are at risk of more severe COVID. Obviously, how does that, I think our data are from non-COVID times, so it would be difficult to say, yes, you can just use the same cutoffs for antibiotic prescribing. But I think, it could be a guide. I mean, it may well be that a lot of patients with COVID have got low CRPs, and therefore that can help to safely reduce antibiotic prescribing. If the CRP is raised, then I think you need to make a judgment as to whether you think that's from the COVID or whether you think there's a bacterial infection.
Thanks. And a couple more here. It's 5 days of antibiotic treatment enough in severe COPD? I imagine this questioner is thinking about those patients with severe COPD who seem to take forever to get better.
Yeah, absolutely. I think you've hit the nail on the head there, Hilary. So there's pretty good evidence. There's actually pretty good evidence from a range of different infections. We're increasingly finding that shorter courses are as effective as longer courses. So there's fairly good evidence for community-acquired pneumonia, for sore throat. So in a range of areas, and there's a meta-analysis for patients with COPD that found that courses of less than 7 days were as effective as longer courses. Sorry, I think it was less than 6 days. There was 10 studies. So there's pretty solid evidence that shorter courses are as effective as longer courses and associated with less adverse effects. So NICE guidance recommends a 5-day course, and I think I would definitely recommend a 5-day course. But as you suggest, Hilary, the important caveat is that the patient isn't going to be feeling better. They're not going to be back to normal after 5 days. So you've got to convey this message that, you know, the antibiotics knock out the bug, but the inflammation takes longer to resolve. So you're still going to be coughing, you're still going to be feeling a bit lousy, but as long as you're not getting worse, you probably don't need more antibiotics.
So maybe although our patients who stop their antibiotics after 3.5 days are probably not so far wrong as we might have thought.
You know, as I say, for community-acquired pneumonia, there are 3, you know, there's studies saying 3 days are as effective. So I think we're definitely moving in that direction.
We've got perhaps 30 seconds for the next question, and then I'm going to have to move on to the next speaker. Is there any benefit from submitting sputum cultures in COPD exacerbations?
Well, I think probably not routinely is the answer. Certainly for a patient who is not responding, who's got clinical evidence of a bacterial infection, is just not responding, that would be a good idea, and possibly in a patient who's had multiple recent courses of antibiotics, but it's not particularly helpful in primary care on a sort of routine basis.
Thanks very much indeed. I'm going to have to move on. There are a few more questions that we may come back to if we've got time at the end. So thanks very much, Nick. Really interesting talk. And now I'm delighted to introduce a colleague of mine from Edinburgh, who's Professor Stuart, and he's going to talk to us about multimorbidity. Stuart Mercer is the absolute guru on multimorbidity as far as I'm concerned. I've learned a lot from him. He is also a GP, and he's done some really fascinating work, along with some really fascinating graphics, Stuart, which made your paper in the Lancet, I think, on the multimorbidity of people in Scotland. So COPD is a very specific condition. We know there's a lot of multimorbidities, so thanks very much for talking us through some of the important issues.
Great, but thanks, Hilary, for that introduction. I don't think I'm any sort of guru, but thanks for saying that. So hi, everyone. I'll crack on because of time. So hoping I can share my screen from beginning. And I'm assuming you can all see that. Yeah? All good? All good?
All good.
So, multimorbidity, what is it? So, it's been defined by the Academy of Medical Sciences as 2 or more chronic conditions, each of which is either a physical NCD, such as COPD, a mental health condition of long duration, and importantly, infectious disease of long duration, such as HIV or hepatitis C. But to all intents and purposes, we tend to simply define multimorbidity as 2 or more chronic conditions, mental and or physical. And just to differentiate from comorbidity. So comorbidity is when you have an index disease and that patient has got other conditions. So actually my talk shouldn't be called multimorbidity and COPD. It should be called comorbidity and COPD, because COPD is the disease, the index disease in this instance. But never mind, and these terms are kind of used interchangeably a fair bit. Multimorbidity makes a lot of sense in primary care because we often see patients over many, many years and life stages, and what's important at one stage can change into a different condition later on. Why is it important? Well, it's important for a number of reasons, and firstly, it's very common, as I'll show you in a moment. So it's becoming the norm, not the exception, and it's associated, the more multimorbidity you have, then the poorer quality of life is on average, the more hospital admissions and unplanned admissions and higher mortality. And health services are largely organised to provide care for single disease conditions rather than for multimorbidity. I mean, traditionally, things have been set up around systems of the body, specialists for different systems, different organs, and so on and so forth. So we are kind of behind the curve in a sense in terms of the actual need of the population. Hilary mentioned this paper in The Lancet 2012. This was taken from primary care electronic records, about 300 practices in Scotland, and it's data on about 1.75 million people in Scotland, and it's nationally representative of the Scottish population in terms of age, gender, and deprivation level. So to all intents and purposes, this is a snapshot of Scotland. At least it was back in 2012. It's probably got worse since then. And it just shows essentially that as you get older, everybody gets something. Most people over 65 in Scotland have got multimorbidity, 2 or more conditions, and the majority of over 75s have got 3 or more. And there's more people in Scotland with 2 or more conditions than only 1. This slide is the same data shown in a comorbidity way, and I'm not going to go through this in detail, but just to say on the left-hand side, the pale blue, that is the percentage of people in Scotland who only have that condition and don't have any comorbidities. And as the blue becomes darker, then it shows an increasing number of comorbidities. So in COPD, for example, only 18% across the whole population only had COPD, and 47%, nearly 50%, had 3 or more other conditions. So this is why multimorbidity isn't something unusual or strange. It is more or less the norm. It's also socially patterned. This shows the same data by socioeconomic level. And you can see that as people get older, everybody gets some multimorbidity. But when you get it in your life depends on where you live, which is a proxy for socioeconomic status. So the dark green shows the most affluent 10% of the Scottish population, and the dark red shows the most deprived 10%. And you can see that there's a 10 to 15 year gap here, particularly in the sort of middle age group, where people in deprived areas are getting multimorbidity 10 or 15 years younger than people in the affluent areas. So clearly this has implications for health inequalities. So that was a quick run through the broad issues of multimorbidity, but I'll talk a bit more about COPD. There's no need for this audience, I'm sure, to be told about what it is, so I'll skip that. I'm going to talk about a paper we published 2017 on the same data set, the 1.8 million people in Scotland, but we looked at this in terms of COPD as the index condition, and we looked at the comorbidities associated with it. It's a cross-sectional study, the largest in the world at the time. I think it probably still is. And the aim was really just to very simply evaluate the prevalence of comorbidities, physical and mental, in people with COPD, and to compare that with to the population without COPD. And as I've said, it was cross-sectional, and we looked at people over the age of 24, so 25 and above. So the sample size was a bit smaller than the full sample, 1.2 million. So what did we find? Well, we found that we had a large number of patients with COPD, so about 4% of the total population aged 25 and over. 86% of those diagnosed with COPD had at least one additional condition. That was compared to 49% of people without COPD. And 22% of those with COPD had 5 or more other conditions, compared with only 5% of those without COPD. So really a pretty massive level of comorbidity in COPD. And when you adjust for age, gender, and deprivation, so you're sort of comparing like with like, then you can see that the odds of people with COPD having 2, 3, 4, 5 or more conditions increase massively. So the biggest increase was the biggest difference between those with and without COPD was actually in people with 5 or more conditions. So typically, therefore, in COPD, you're getting very severe levels of comorbidity. In terms of the mental and the physical conditions, we looked at 31 physical conditions, and 29 of those were more common in COPD. And in terms of the mental health conditions, we looked at 5 of the 7 were more prevalent in COPD than those without. Sorry, I hope you're not hearing my dog barking outside. In terms of the most prevalent non-respiratory comorbidities, then these were the common things: hypertension, painful conditions, coronary heart disease, depression, dyspepsia, and diabetes. And again, when we looked at this in terms of adjusted odds ratios, so adjusting for age, gender, deprivation, then although hypertension is the commonest, the increase isn't as big as for other things such as depression, coronary heart disease, and chronic pain. And just to say that our findings were more or less repeated by a paper the following year by Peter Hanlon on a smaller sample, but a UK-wide sample using UK Biobank data, who found broadly similar results. And what Hanlon and co also looked at was polypharmacy, which we didn't look at, and found that 52% of those with COPD were taking more than 5 medications a day, compared with only 18% in those without. And we're more likely to be prescribed more than 3 medications, medications which potentially would contribute to quite serious side effects, including falls and so on and so forth. So it's polypharmacy is common, and it's not without its risks. And again, in the adjusted odds ratios, the biggest increases between COPD and non-COPD patients was things like bleeding, depression, and so on. So just to begin to wind up here, I just did a quick skim of the literature the other day to see what had been published since these 2 papers. This was quite a big study from Canada, and they found that in terms of the costs of COPD, then COPD patients generated excess costs of around £4,000 per patient. I've converted this into pounds, but actually only 26% of that was attributable to COPD and 51% to comorbidities. The remaining percentage couldn't be attributed. So that's really important in terms of the cost to the health service. Increasing numbers of comorbidities increase all-cause mortality rates in COPD, pretty much as you'd expect from the multimorbidity literature, but good to know that it's more or less the same in COPD. So it has pretty serious consequences. There's a lot of work now in multimorbidity research around clusters of conditions, and this has been looked at, and the number and complexity of clusters of comorbid conditions in COPD, not surprisingly, increases with age. So there's not actually some nice, neat, 3 or 4 conditions that you can say, well, if only we could treat those, everything would be fine. It's not like that. It's complex. It changes with age. It changes with socioeconomic status. And then fatigue, a very common symptom in COPD, is again related to the number of physical and mental comorbidities that people have. So just in conclusion, comorbidity and multimorbidity is pretty much the norm, not the exception. There's extreme multimorbidity, so this should say extreme comorbidity in COPD. With 1 in 5 patients having 5 or more additional conditions. This excess multimorbidity includes mental as well as physical health conditions. It leads to polypharmacy, adverse drug reactions, and higher morbidity and mortality and higher healthcare costs. We don't have an answer to this, but clearly part of the answer has to be holistic generalist care, well integrated with specialist care. And of course, social care is likely to be essential for the effective and cost-effective management of patients with COPD. Thank you very much.
Thank you very much indeed for that, Stuart. Some really, really telling statistics and figures there. You know, this sort of 1 in 5 of our COPD patients have 5 or more multimorbidities, comorbidities, and it's complex. So how do we deal with this? I mean, I'm a GP, you're a GP. What have we got to do in our practices to address this issue? Most of our nurses are trained. I've got respiratory nurses, I've got diabetic nurses, I've got some wonderful cardiovascular nurses. How do I change my practice to deal with this situation, Stuart?
Well, I don't know, Hilary, sadly, because we don't have an evidence base. So when I say I don't know, I mean we don't have good evidence for interventions that would improve outcomes in multimorbidity in general. And I haven't seen any in COPD in particular, although I have to say I'm not an expert in COPD. So in the absence of hard evidence, then what do? I think we need to do the usual things of making sure that we're not doing things to patients, but we're involving them in decisions. You know, in Scotland we have realistic medicine, and I think where more would that apply than to somebody with COPD with 6 or 7 other conditions? What does the patient actually want? And I think the polypharmacy is something we potentially can do something about. And unfortunately, as patients see different specialists, or that we follow different guidelines, the polypharmacy just stacks up very quickly. And, you know, I think all of us are maybe not always aware of the adverse side effects and the potential for harm. That's maybe where working with community pharmacists now in integrated primary care teams will be a big help. But unfortunately, I don't have the answer. I hope somebody else on this call does. I would say, of course, we do need more research. And although I would say that as a researcher, I think in this it's absolutely true.
Yeah, absolutely. I'm thinking that there may be some nurses, respiratory nurses perhaps on this call, who are thinking, when am I going to have time to address all these 4 or 5 multimorbidities?
Yeah, well, well, exactly. And you can't do it in a 10-minute consultation. So, I mean, I think, I know many practices are moving towards having, you know, like an annual review that's a multimorbidity review. As a kind of one-stop shop. In fact, I was part of a big trial called the 3D study, led by Chris Salisbury in Bristol, where we did just that. Unfortunately, it didn't show any benefit. It didn't make anything worse, and the patients liked it. The patients loved it, but it didn't improve outcomes. But in that, it took about you know, a 40 to 45-minute review, initially by a nurse, and then linking that with a GP follow-up. I think these forms of integrated models are the way forward. The exact constellation of who does what and when, I don't think is entirely clear. And we do have things like the House of Care model, which is, you know, popular, but again, not with a strong evidence base behind it.
There's a particular question here that's come in from Liz, about what is the prevalence of osteoporosis in COPD?
We didn't have data on osteoporosis as far as I recall, so I don't know personally. I expect it's well above that of the age and gender and deprivation match controls. Because yeah,
it definitely is. That the Hunt work in Norway showed very clearly that. I can't remember the figures off the top of my head, but very definitely both because of the immobility or relative immobility of these people, but also of course because of the steroids.
Yeah, exactly. So, but I don't have the exact thing, the exact figures. I'm sorry. I'll try and look it up for you.
And there's one here about in Ireland, we're setting up chronic disease management hubs and clinics. Maybe this will work for COPD and multimorbidity.
Yeah, yeah, and I think there's quite a lot of this going on in various places. I mean, in the absence of good big RCTs that lead us into what to do, of course, as clinicians, we have to try things. And actually, I think in some ways, we might see that practice-based evidence is going to be very important in helping fill some of the evidence gaps in the future, because it's not all about trials. Trials are very important. So yeah, absolutely. And my plea to anybody doing anything, try to get some evaluation done.
Yeah.
Even if it's light touch, it all helps.
Yeah. Yeah, thanks very much indeed, Stuart. Really very, you know, sort of food for thought, isn't it, as to how we manage these people with these complex problems. Thank you, Stuart.
Okay, thank you.
And I need to also thank Joanna O'Callaghan from our audience here, who's come up with the perfect link to our next speaker, which says, what proportion of comorbid conditions are due to smoking? Well, I didn't ask Stuart the question because I think there's an answer is a fair number of them, but it leads me beautifully into our next, our final talk today, which is from Suzanne Scott, who studied at Paisley, and she's been working with NHS, Ayrshire and Arran, and she's been working on the Fresh Ayrshire project, which
it's
I
quite
believe
your,
is spelled
quite your way now.
Air.
It was Fresh Air,
just,
so it's now quite your way.
Well, I rather liked the pun, Suzanne, of the Fresh Air. But anyway, she's going to talk to us about tobacco prevention, helping people to quit smoking. As I said at the beginning, if there is one thing that makes a difference to the outcome in people with COPD, it is quitting smoking. And as somebody has, Joanna's already pointed out, it's also responsible for many of the comorbidities. So a really important topic for us to think about. Thanks, Suzanne.
Right, I'll just share the screen. Where's my just go back to the beginning here. Right, sorry about that, folks. Okay, so yeah, my name is Suzanne Scott. I'm a tobacco prevention and cessation officer, and I work for the Quit Your Way Stop Smoking Service. I have done since November 2007. It was formerly known as Fresh Ayrshire, and part of my job is to support clients to stop smoking. And so this presentation tonight is about how other health professionals can offer support and advice to patients and refer them to our services, so that in the form of very brief advice. So just a wee bit of background. Smoking in Scotland, as you're all probably very well aware already. So these stats were taken from ASH Scotland, which is a charity which is Action on Smoking and Health. And at the moment, as it stands, the Scottish estimated number of adult smokers in Scotland is 858,533. That was taken in 2017. It is coming down. Scottish National Adult Prevalence dropped from 28% in 2003, 21% in 2013, and is now down to 18% in 2017. So constantly working, obviously, to get those figures down. There are over 10,000 smoking-related deaths a year in Scotland, and around a fifth of all deaths in Scotland are related to tobacco. And in smoking, amongst age groups aged 35 to 69, on average, they lose about 22 years of their life are lost for every smoking-related death. So again, a wee bit more background. As everybody's probably aware, smoking is the primary preventable cause of ill health and premature death. Tobacco kills up to half its users, increasing mortality primarily through cardiovascular disease, lung cancer, and chronic obstructive pulmonary disease. Around 2/3, about 70% in 2016 of Scottish smokers say they would like to stop smoking. So you probably find 70 to 80% of people who do smoke actually want to stop. A lot of it is down to confidence, fear, worrying about withdrawals, stress. So that's obviously where the stop smoking service and more intensive behavioural support does help these clients. And according to the National Institute of Clinical Guidelines, these published in March 2018, if a person or smoker wants to quit, a combination of varenicline, which is a stop smoking tablet that you take and it stops the urge to smoke, or a combination of short-acting and long-acting nicotine replacement therapy with behavioural support are likely to be the most effective. So if a patient or a smoker uses like Champix or nicotine replacement therapy, that'll be patches, which would be your long-acting, your short-acting would be like gum, lozenges. They're twice as likely to stop smoking. If they use it with behavioural support, they're four times more likely to stop smoking. So again, this is evidence-based stop smoking interventions. The NICE guidelines in 2018. So as you can see, behavioural support, nicotine replacement therapy and varenicline are up there, but also very brief advice is now an evidence-based intervention. So what is very brief advice? Well, very brief advice is an evidence-based intervention designed to increase quit attempts amongst patients who smoke, and it was developed by the National Centre for Smoking Cessation and Training. So they do a lot of training online, and at the end of this presentation I've got a short video clip I can show you, just showing you basically how important very brief advice is. This is actually, it's been tailored to make it a shorter intervention, because it has been recognised that a lot of healthcare professionals, GPs, time can be a factor. Also, they don't want to jeopardise the relationship with them and the patient, you know, by seeming to preach or give talk about risks or medical advice, because most patients know that smoking is bad for them. So what it was before, it was brief advice, and that would take into account giving patients advice and stopping smoking, but also giving them risks of smoking and the health effects of smoking. So that's now been taken out of the equation. So instead, for healthcare professionals are in a good position to offer advice as to patients with conditions caused or exacerbated by smoking, and should use every opportunity to give advice to smokers and enable access to NHS stop smoking services. So basically what this means, whether a patient expresses a desire to stop or not, at every consultation, particularly healthcare professionals in primary care settings, they're seeing patients several times a year. They should be asking the patient every time they see them if they smoke, or if they have given up smoking, if they're ex-smokers, are they still stop smoking? Because evidence suggests that 70% relapse. So should be asking patients within 3 years if they are still stop smoking. Very brief advice is supposed to support all smokers regardless of their present motivation to quit, and it's a non-confrontational, opportunistic, patient-centred method taking less than 30 seconds. So all smokers should be advised to stop smoking and offered evidence-based support even if they've not expressed a desire to stop. So again, that would be a combination of behavioural support through a local stop smoking service, or if there's in-house stop smoking service advisor like in a GP surgery, along with nicotine replacement therapy. So all primary healthcare professionals should use the Ask, Advice and Act model for provision of very brief advice and support, and I'll go through that in a bit more detail with you. Again, there's a short training module on very brief advice, and it's available at the NCSCT website, and the link's there. So that's the National Centre for Smoking Cessation Training. It takes you through very brief advice. It's quite straightforward. It's video clips. It's for all healthcare professionals. It's primarily kind of directed at GPs on the actual training, but I think any healthcare professional in primary, secondary, community-based could benefit from this. There's also like frequently asked questions, so it gives you a bit more advice on nicotine replacement therapy if you need that, and various things as well. And there's also, there's assessment at the end as well. So argument for very brief advice, again, Aveyard 2012 conducted a review in 13 studies which concluded that physicians may be more effective in promoting attempts to stop smoking by offering assistance to smokers rather than advising smokers to quit, and rather than just advising assistance also to those expressing interest in doing so. So again, what that actually means is it's not about advising clients to stop or telling them to stop. It is about offering them support. So just giving them that 30 seconds saying, did you know that, do you smoke? Did you know that there is evidence suggests that you're 4 times more likely to stop if you use stop smoking service and NRT, and then obviously referring them on. 3 trials show strong statistical evidence that offering support for cessation motivates an additional 40 to 60% people to attempt cessation compared to being advised to stop smoking purely on medical grounds. And as I mentioned before, it's about more patient-centred. It's about offering that support every time you see them, but not obviously on medical grounds. So it's more just giving them that, offering that support and directing them to where they can get that support rather than going through the medical advice, which most patients really know about. They know that smoking is bad for them. So again, this is from the National Centre for Smoking Cessation Training. So increased chances of stopping smoking compared with no action. So the offer of prescription, 6 to 8% more chances of stopping smoking compared with no action. Again, that's offering nicotine replacement therapy, Champix. Obviously, I work for Stop Smoking Service and NHS Ayrshire and Nairn, and we work in partnership with the pharmacies who prescribe the Champix, and we can offer them extra support at the moment via telephone support because of the lockdown restrictions, but in the past obviously we could offer them one-to-one and group support. The offer of support, as you can see, it increases up to 217%, and there's been a lot of studies across England that suggest that patients are twice as likely to stop smoking if they are offered support rather than given advice to stop smoking. So if they're offered support in terms of what their available options are in terms of behavioural support and nicotine replacement therapy. So this is just the kind of the outline of very brief advice in smoking. So it says 30 seconds to save a life, and that's literally how long it would take a health professional to give that advice, and it can be done during the consultation, the end of consultation. Obviously, like GPs and other health primary care professionals will have access to patient records and notes so they can see whether the patient is a smoker or not. So it would be about asking, recording smoking status. So is the patient a smoker, ex-smoker or non-smoker? They're just asking simply, do you smoke? Are you still a smoker? Have you stopped smoking? How are you getting on with that? Advising the best way of quitting. So again, just going through that, the best way of stopping smoking is with a combination of medication and specialist support. And studies have shown that by giving this advice, patients are more receptive to it. It's more client-centred. It's given patients, clients, smokers the option whether they want to stop or not. Because if you give them that advice, then you can then act and say, I know it's difficult to stop smoking, but obviously the support is available, and then giving them that information. Might find that some patients don't want the support, but they just want the nicotine replacement therapy. In that case, it'd be a case of just giving them that prescription. We'll be seeing them every 2 weeks for 2 to 3 months, total of 12 weeks, because obviously that's better than no support at all. But again, just emphasising that they're better off with the behavioural support and the nicotine replacement. So it's about building confidence, trying to be empathetic, listening, but not entering into too much of a dialogue with them, because that's obviously more suited towards the behavioural interventions like the stop smoking support, more intensive support. So you don't need to go into detail about how many they smoke or how many cigarettes they smoke or anything like that. It's just about giving them that kind of very brief advice. and then again refer them to their local stop smoking service. So why very brief advice? Again, just to summarise, the advice from health professionals is one of the most important triggers for a quit attempt. Very brief advice is designed to deliver effective advice without taking up too much time or harming the relationships with patients. Again, a lot of, as I said before, if you're seeing patients several times, you've already probably built up that rapport with them anyway. Very brief advice does not attempt to deliver more intensive counselling techniques. And if a smoker is interested in quitting, they're offered behavioural support and medication wherever it is locally available. So most areas will have a local stop smoking service and hopefully have that information to hand. To increase chances of stopping smoking are 2 times more likely to quit sport and 4 times more likely to quit with support and stop smoking products. And research has been given in 2020 that overall GPs had a very positive experience with using very brief advice. They found the method to be efficient as to the time involved, patient friendly and easy to implement. At the moment, as it stands, we don't have a lot of evidence to really say how often very brief advice is given, but the evidence is there that it could be implemented a lot more throughout GP surgery. And if very brief advice is widely used in general practice, it's expected many more smokers would probably attempt to quit smoking. And as obviously we've mentioned about COPD, which is the biggest, smoking's the biggest cause is COPD and heart disease, and that this is, the best way to support people who do smoke. So it's just a couple of quotes like from research studies. So by GPs, so what we've learned is not to preach too much, but simply to give quick advice, and this is enlightening. And I actually already did it, but I think I do it more often now because I do it in less time. So the way forward, again, there are many factors influence of smokers' motivation to quit. So it may be that you have to give it routinely on several occasions, but hopefully one occasion it will, will trigger off that all-important quit attempt. So very brief advice may not bring about an immediate quit attempt, but will sow the seed or trigger future quit attempts, or when advice is given at the right time, the patient will finally make a quit attempt. And remember, according to NCS CT training, simply advising individuals to stop doesn't work and involves a referral to your in-house advisor or your specialist local NHS stop smoking service. And this is just a wee bit background. It will be general, different areas be different, slightly different, but the general support is the same. So what we offer is behavioural support via groups and one-to-one. Pre-lockdown, obviously we did kind of drop-ins, group support, and we found that a lot of clients that went along to this, they kind of supported each other, and it's a good environment for that, plus getting the advice and support from a specialist stop smoking advisor. Regular telephone support and near me appointments available. So at the moment that's what we offer, telephone support plus nicotine replacement therapy, and patients are 3 times more likely to stop if they get this support. And near me is more about just giving them that video link as well. We also provide a cut down to quit service, which is 4 to 6 weeks. So perhaps smokers are not as confident, they get that kind of bit more tailored support, and it's not time limited, the actual behavioural support. We can support patients for however long they need to be supported, providing free nicotine replacement therapy for 16 weeks. Carbon monoxide monitoring, which obviously we're not doing at the moment, it's just to test the levels of carbon monoxide of a patient or client. And also work with people who use e-cigs, so it's an e-cig friendly service as well. We can't obviously prescribe e-cigs, but we can support people who want to use the e-cigs, and they can use the e-cigs along with nicotine replacement therapy, such as patches as well. A free national helpline is open 8 AM to 10 PM, and that's the free national telephone number or helpline number, and that if you phone that number, if you say you were referring patient, you could give them that number, or you could phone through and get the referral, put the correct service so that they can get to the correct behavioural support in their local area. But most, as I say, most Quit Your Way stop smoking services will have their own local stop smoking service. And this is a quick video clip.
Not sure we've actually got time for a video clip at the moment, Suzanne,
Oh.
because we've sort of got to the end of the time, and I did want to bring Stuart and Nick back in whilst I
Okay.
ask a couple of the questions that have come up for you. One of the ones that perhaps while Stuart and Nick are getting themselves back online, there's one here about vaping. I've lost it now. What is your opinion of vaping? I've lots of patients vaping for many years after stopping smoking.
Right, okay. I mean, vaping, it's in terms of harm reduction, vaping it is a lot safer than smoking. There's maybe about a 5% risk, although there are lots of different types of e-cigs. I suppose it's not ideal if someone's been on it long term, but as I say, it's better than smoking. We do try and work with patients to try and reduce their vaping and hopefully come off the vaping, but we use it in conjunction with nicotine replacement therapy. At the moment, there's still ongoing studies and the jury's out about how harmful these cigs are. So as I say, it's not ideal to be using it long term, but as it stands in comparison to smoking, it is safer. So that's basically, but we would try and work with clients to try and get them off the vapes and help them that way.
It's a contentious issue. The European Respiratory Society are absolutely against vaping, and I know that the UK have a pretty almost unique, I think, in acknowledging a potential role for it. So it's quite an interesting debate. Okay, so I've got a few questions and I'll share them out and see how many we can cover, but I'm sure that if there are questions we haven't covered, Nick and Stuart and Suzanne will be happy to just try and type a quick response in. We'll make sure we keep the questions. So there's a couple here around action plans for COPD exacerbations, Nick. Do you advocate patients have their rescue medication at home, and would you include antibiotics in a COPD action plan?
Well, NICE do recommend providing patients with self-management medications, but there's actually, the evidence is fairly scarce. So there's not good evidence. I think, to me, the key thing is about the advice that's given with the medication pack. So as you say, the action plan, patients need to have a clear understanding. Certainly sputum purulence is something that patients can assess by themselves, particularly if they are given access to a sputum color chart like I showed you. There are ones available online. And there is actually a trial going on at the moment evaluating the use of sputum color charts given to patients as part of their rescue packs. So we don't have conclusive evidence, but I would say if you are going to give patients antibiotics, then it's all about the information that you give them. I certainly don't agree with the sort of whole, you take both your steroids and your antibiotics if you're going to take anything. So there are two different medications and they've got different uses. In fact, the evidence suggests really that probably they're kind of mutually exclusive, that the patients who benefit from steroids are less likely to benefit from antibiotics and vice versa. So I hope that answers the question.
Well, that is interesting, and it answers another question about simultaneous prescribing of steroids and antibiotics, which are almost one thing, aren't they now? I'll give you some steroids and antibiotics. It's almost like one treatment in people's minds, I think.
Yeah, I mean, the patients that are most likely to benefit from steroids are the ones with the eosinophilic inflammation, and there are ways of measuring that, and again, there's research going on to sort of see whether by measuring either a serum or sputum eosinophilia, whether that's helpful in guiding steroid use, because that's also problematic in overuse of steroids. At the moment, guidance largely says, well, if the patient's significantly more short of breath, well, that's almost by definition most of these patients aren't they? So I think there is even more liberal use of steroids, and hopefully we can address that issue with time.
Which brings us back to the osteoporosis question that we were asked earlier on as well. So, I mean, it is a challenge. Pretty much a one-word answer to this because I want to move on to another topic. But do patients run true to type if they are usually needing antibiotics because they have bacterial causes for their exacerbations? Is that likely to be the case for most of their exacerbations, or is there no sense in which they're true to type, so you can, if you like, type people?
There certainly is a fair degree of, previous exacerbations are somewhat predictive of future exacerbations. It's not absolute, but yes, people who tend to have more bacterial, purulent exacerbations are more likely to have subsequent ones.
Okay. Thanks.
And of course, those who are eosinophilia, if you've got a patient who's got high levels of eosinophilia, then they're more likely to have subsequent eosinophilic exacerbations responsive to steroids.
That's helpful, and because somebody's already said that they don't have CRP. Nobody has yet admitted to having point of care testing for CRP.
I don't have it.
So we're all going to have to rely on clinical means for the moment. Stuart, can I come to you about that question about the comorbidity, and is it really the smoking that's responsible for this? I glossed over it before in order to move on, but can we come back to that? Is that what's responsible for all this comorbidity?
I think it's a mixed picture. Okay, so what I didn't go into tonight was the different types of comorbidities you can get with any condition. Some of them are so-called concordant, where the kind of pathophysiology is similar, and some are discordant, where there's no particular clear sort of linked pathology, if you like. And it's like, how long is a piece of string? Because it really depends how many conditions you include. So like in our study and the data I showed you, chronic pain was very, very clearly very common. Now, many studies just wouldn't try to measure that. And is chronic pain discordant or concordant? It's a bit of both. Is it due to smoking? Probably not. But is the coronary heart disease linked to the smoking? Absolutely. So I can't give you a figure, and I would say it's not only smoking. I mean, I think in coping with comorbidities, it's also general lifestyle. So it's SNAP, smoking, nutrition, alcohol, and physical exercise. In general terms, lifestyle things like that maybe account for 50 or 60% of multimorbidity. We don't know all the other factors. I mean, there may well be direct effects of things like deprivation, for example. So I don't have a very clear answer. Smoking doesn't cause all the comorbidities, but will certainly be linked to some of the very important ones.
Yeah.
So no doubt stopping is a good idea.
A nicely balanced answer. And one more for Suzanne, for you, fairly quickly, because we're sort of getting quite short of time now, about resources modules for supporting patients who are interested in stopping but don't feel quite ready yet to make an attempt or be referred. Is there a resource that you have for those sort of people? So can you hear, Suzanne?
Well, we do have leaflets and things for stopping smoking and things. So obviously ours is more locally tailored, but there is general leaflets as well. I suppose it's about, if they're not quite ready, it's just about planting the seeds and giving them the information so that when they are ready, they can get in contact with the services as well.
So you have got some information, and there's somebody who wants to know about how to find out about the local smoking cessation services, but I think you had those telephone numbers on one of your slides.
Yeah, I think just depending on the area. Obviously, I work in NHS Ayrshire and Arran, so we've just got the local number for NHS Ayrshire and Arran, but if you're wanting to find out what your local stop smoking there is, you can just go into Quit Your Way. There's a website and it'll give you the national helpline number, but it's also on my presentation as well, and they would then direct you in the direction of the local service as well.
We've run out of time and we've only got one question left, and it was for you, Nick. So maybe if we can send it to you. It was about azithromycin, a prophylactic azithromycin. So maybe if we can forward that one to you. But thank you very much. That has been a really interesting webinar. We've looked at some really important things around COPD, and I'm very grateful. Thank you very much to Nick, Stuart and Suzanne for giving us your time and your expertise. Really, really excellent webinar. Thank you too for Clara and Wendy, who've handled all the admin for this. This wouldn't happen without them setting it all up and dealing with the administrative aspect. So thank you very much. Thank you very much too to Viatris and GSK, who have provided us with the with a grant to enable us to do this. We have got another webinar coming up. We haven't actually got a date, but it's likely to be towards the end of May, so watch this space. And this time it's on hay fever and eczema. We're making the assumption that by the time we get to May, we're well and truly into the hay fever season, so this seems a very ideal thing to be thinking about towards the end of May. And finally, thank you to all of you in the audience. You'll be able to see this again if you wish to on YouTube. Tell your friends, and they can also log in and watch it on YouTube. So thank you very much to everybody, and good night to you all. Good night.
Good night.